We are moving into plenary 1. This is a very important part of this scientific conference, and we are going to have an international guest speaker to talk to us about evaluation and management of menopause. As you know already, menopause is one of the sub-themes of this conference, and a great deal of talk has taken place concerning this. To do this afternoon, we will be having the honor of hosting one of the world-renowned endocrinologists that is a Nigerian, that is a friend of ours, Professor Sanjay Kaura. But before he delivers his lecture, we will get a brief recap of his biosketch by Dr. Olopade before we proceed. Thank you.
Okay, thank you. I'm sure his biosketch is on our conference site, and it's also in our brochure. So Dr. Sanjay Kaura, or Dr. Sanjay Ayodele Kaura, that's his middle name, is a consultant endocrinologist and head of Puberty Hospital in Kauna, Haryana, India. He's the treasurer of International Society for Endocrinology, the vice president, South Asian Obesity Forum. He's also the editor-in-chief, ESI textbook of endocrinology. He's a highly respected consultant endocrinologist and serves as head of departments of Puberty Hospital in India. He also holds a DM in endocrinology from All India Institute of Medical Sciences, New Delhi, and an MD in medicine from Maharishi Dayana University, Rohtak. His foundational medical education was obtained from Punjab University, and he played a significant leadership role in several national and international endocrine associations, serving on executive boards and education or advocacy working groups of International Society of Endocrinology. He is the president-elect of South Asian Federation of Endocrine Societies and a former president of the Endocrine Society of India. Dr. Kaura is deeply involved in academic teaching as a visiting and adjunct professor at several institutions, including AMS and the University of South Wales, United Kingdom. His leadership include roles in medical education, examination, organizing scientific congresses across South Asia. He's a prolific academic. He has edited multiple authoritative textbooks in endocrinology, including Endocrine Society of India textbooks of endocrinology and Manual of Clinical Endocrinology, Diabetes, Obesity, and Insulin Therapies. He has contributed significantly to scholarly publishing, having served as editor-in-chief or section editor or executive editor and editorial board member across numerous international journals such as Diabetes Therapy, Diabetes Medicine, and Endocrine Society of India publications, among others. Dr. Kaura has received several national and professional awards in recognition of his work, including the A.V. Gandhi Award for Excellence in Technology and Dance Award and Fellowship from Leading India Medical Society. His clinical research contribution are substantial, having served as the principal investigator in over 50 international clinical trials and major national studies, such as the ICMR India survey in Haryana. He's a globally recognized speaker, having delivered over 1,000 lectures across all continents on diverse topics in endocrinology, diabetes, and obesity, with more than 840. When I checked online, it is over 1,000 on PubMed, really, index on PubMed. So Dr. Kaura's work span a wide array of subjects, including injection therapy, thyroid disorders, insulin therapies, diabetes care model, and obesity management frameworks. His contribution has constantly bridged clinical evidence with practical approaches in endocrinology, earning him recognition as a leading voice in the field. So this afternoon, I want us to welcome Dr. Kaura as he presents Menopause, the evaluation of menopause.
I am Dr. Sanjay Ayodele Kalra. It's been a long time since I was born in Ibadan and since I did my O-levels in Kaduna and Zaria. But I remember Nigeria fondly and I hope to be back soon. Today, let's talk about menopause. Me, no pause. I will not pause. I will continue living life. Why is it that we need to speak about menopause today? That is because, first of all, our life expectancy is growing. If you look carefully, almost all animal species die out as soon as their reproductive phase of life is over. Human beings are an exception. Our reproductive phase finishes around the age of 45 to 50, but we keep on living after that till the ripe old age of 70, and in Japan up till 100. Menopause occurs at the age of around 47 to 49 in women across the world, but because women will continue living after that, we have to manage their health. These changes that occur in the female reproductive cycle are a normal part of aging. Same thing happens in men as well. The hypothalamus and pituitary respond to the weakening of the ovary. LH and FSH rise. FSH is used to diagnose and to confirm menopause. The ovaries stop working. When the ovaries stop working, we have less of not only estrogen, but also the other hormones. And this is a natural part of life. It is a natural part of aging. When the estrogen declines to a particular level, you have cessation of menses, and that is what menopause is. Menopause is defined as 12 months or more of loss of menstruation. Of course, if there is a surgical menopause, you can diagnose immediately. These changes are associated with many M's. Menopause can be associated with mood disturbance, motor or vasomotor issues, micturition and genital atrophy, musculoskeletal complaints like osteoporosis and sarcopenia, metabolic syndrome, and also mitogenic conditions or malignancy. Some of these are associated with osteopenia more than others. For example, mood, vasomotor, micturition and genital issues are more associated with estrogen deficiency. And it is menopause hormone therapy which has an important role here. Osteoporosis is one syndrome where MHT has an important role to play. But when we manage menopause, do remember that you are managing not only estrogen levels, you are managing the woman, the lady in front of you, and you are also managing her family. So we need to have a holistic understanding of the disease, not only the etiology, but also our efforts at management and our aim of therapy. All this we should understand. It is important because in postmenopausal women, you see that, of course, mortality will increase, but there is no significant association between age at mortality, age at menopause, and final mortality. And you can compare hysterectomized women or oophorectomized women with those who have natural menopause. It has been a long time, and many people have studied hormone replacement therapy, or the new term now is MHT, menopausal hormone therapy in postmenopausal women. More than 30 years ago, it was shown that estrogens are beneficial in improving health, though of course they increase endometrial hyperplasia. When hormonal therapy was given, that is estrogen plus progesterone, there was a lower LDL and higher HDL. Even though there were more coronary events or coronary heart disease events at year 1, these coronary events had reduced by year 4 and 5. The game changer was the Women's Health Initiative. This was a very large study done in 161,000 plus women participants. They were randomized to 2 groups, conjugated equine estrogen alone in one group and conjugated equine estrogen plus hydroxyprogesterone acetate in the other. The aim was to assess them for long-term outcomes, cardiovascular disease, cancer, hip fractures, other chronic diseases, and mortality. The aim was not to look for short-term well-being. The aim was not to see whether they responded to hot flashes. With treatment, their hot flashes improved or their genitourinary symptoms improved. It was a long-term study. When the results came out, it was found that estrogen plus MPA plus progesterone was actually helpful in reducing hip fracture, in reducing endometrial cancer and colorectal cancer. But when you looked at the overall mortality, there was no improvement. The results were studied in such a way they were sort of assessed or explained in such a way to show that estrogen therapy has no benefits. Even though estrogen therapy alone was statistically significant in reducing hip fracture. Is it because, in general, publication and opinion building is handled by men? Is it because there is a gender bias? If you yourself are a woman, you will have a different attitude towards a lady who comes to you with hot flash or who comes to you with genitourinary complaints. On the other hand, if you're a male endocrinologist who doesn't have experience of these things, even though men themselves may have hot flashes, you may have a less sympathetic attitude. Was it because of this, or was it because of the fact that the wrong people were included in WHI, in Women Health Initiative? And this is actually true. Most of the people who were included were women aged more than 60. They did not include women with early or premature menopause. They used only one type of HRT, oral, one type of formulation, one dose. They did not try other types of HRT, and the modern progesterones that we have were not tried. Of course, the early increase in CV events was attributed to plaque destabilization and rupture. At that time, we did not have good quality statins or ACE inhibitors or ARBs to prevent such issues. Other studies later on have shown that when you give transdermal estrogen or oral conjugated equine estrogen, there is no difference in coronary outcomes. Also, the increase, even if it is there, is with placebo is minimal. The WHI actually impacted HRT prescription to a great extent. And the bad thing is that women who were suffering from symptoms of menopause, symptoms of estropenia, did not get the required treatment. So let us try to set things straight. As endocrinologists, we need to lead opinion building in our country, in Nigeria. We need to explain to each and every person, each and every stakeholder, each and every influencer. We need to explain that menopause is associated with unhealthy metabolic milieu. Menopause is more than endocrine transition. It is more than medical disease also. It is a biopsychosocial syndrome. We may not call it a disease, but certainly women who are affected by dysfunction, by disability, they know that they need treatment. It is our duty to take a good history, to do a good examination, to do the right investigations, and make sure that the right patients, the right women get the right MHT, menopause hormone therapy. That is our duty as endocrinologists. So we begin with history taking. But for history taking, we need to understand the subject ourselves. So we'll talk about various impacts of influences of menopause on metabolic health, cardiometabolic health, and musculoskeletal. We'll also talk about each and everything under the sun. Now, the FDA-approved indications for estrogen for MHT are vasomotor symptoms, prevention of osteoporosis. Do note that when you are using denosumab or bisphosphonates or teriparatide, that is for treatment of osteoporosis. But if you want to prevent postmenopausal osteoporosis, FDA has approved estrogen. MHT is also approved for women with premature menopause, with primary ovarian insufficiency, maybe Sheehan syndrome, and bilateral oophorectomy. If the patient has only local symptoms, then you can give low-dose vaginal therapy as well. This is also approved by FDA. It is important because vasomotor symptoms, the hot flash that our patients complain of, are an anginal equivalent. Frequent vasomotor symptoms, bothersome vasomotor symptoms, are associated with worse cardiovascular outcome. So, just like diabetes is an anginal equivalent, vasomotor symptoms or symptomatic menopause is also an anginal equivalent. Vasomotor symptoms are also associated with low BMD, osteopenia, osteoporosis. So they are a fracture equivalent, and we should not ignore these facts. We also understand that if you give MHT in timely manner at the right time, then you can get benefits. So not only in monkeys, but also in human beings. Not only for cardiovascular effects, but also for cognition and bone. If you use MHT in a timely manner, then you will get benefits. So hit early, hit hard, hit as soon as possible with the best treatment available. And this is similar to what we are following in diabetes. Just like in diabetes, we use the word glycemic legacy and metabolic memory. Here, we will use the terms estrogen legacy or estrogen memory. If we can give estrogen progesterone for a longer period of time, we will be able to prolong health, prolong life, not only quantum but also quality of life. And the cutoff is something like 10 years after menopause. If you give HRT for up to 10 years after menopause, you have a benefit. If you use beyond 10 years, then you will have no benefit. One of the commonest complaints that women have, it is up to us to take a history, is what happens to them locally. They may have vaginal dryness, irritation, itching, dyspareunia, nocturia, dysuria. All these are worsened by the SGLT2 inhibitors that we use. Sometimes women are too shy to complain. So you ask a question, you ask in very soft way. Suppose you are a male healthcare provider and the lady comes to you, she is very high. You might want to ask non-threatening questions. So, madam, how are you doing? How is your quality of life? Okay. Madam, any lower abdominal pain? Madam, any infection anywhere in the body? Any cough, cold, any skin infection, any urine infection? Ma'am, any issues while being part of the family? Do you face any problems as a mother, as a wife, as a daughter? When you ask these kind of questions, the patient doesn't feel threatened. And finally, you can go to asking about urinary or sexual symptoms. If you feel uncomfortable yourself, you can ask a lady colleague, even if she is a non-medico, an assistant, to ask these questions. And you will be surprised. So many people will come and tell you that they have these complaints, but nobody ever asked them. They never knew that they could share this with the doctor. And when you tell them, we have a treatment for you, madam, we can help you with this gel or with this tablet, they are so grateful. That is the best part of being an endocrinologist. But another good part of being an endocrinologist is that we know that if menopause occurs early, the risk of diabetes and metabolic syndrome goes up. So if we can maintain estrogen levels for a longer period of time, we can also prevent diabetes. If we can prevent vasomotor symptoms, again, we can increase insulin sensitivity and prevent diabetes. And this is a very significant prevention, 20 to 35%. Even in the WHI, that also showed that there was 21% risk reduction in type 2 diabetes with MHT. And as the diabetes epidemic hits us, we have to be more observant, more careful of this. We are all aware of data from the Global Burden of Disease 2021, which shows that Nigeria is becoming more and more obese. And by the year 2050, Nigeria will have the 4th largest number of people in the world living with overweight and obesity. That overweight and obesity will come with diabetes, will come with various aspects of metabolic syndrome. And if we can reduce the risk in our menopausal women by giving them MHT when indicated, that will be a great service for womankind. It will be a great service for the nation as well. MHT actually reduces insulin resistance, new onset diabetes, and can be prescribed to women irrespective of their glycemic status. Of course, you must look for CV risk and do look for triglycerides. If serum triglycerides are very high, then perhaps transdermal estradiol, 17-beta-estradiol, will be a better choice. But otherwise, you can use any kind of MHT that is available. Metabolic syndrome is not only diabetes, it is multiple other things, and all these should be managed. Another challenge that we will face is how to manage polycystic ovary syndrome women after menopause. There are no detailed guidelines for that, but one of the ways of managing them is to give MHT. Nearly 14 years ago, showed that the prevalence of metabolic syndrome in Nigerian women with type 2 diabetes is 69%. Obviously, we have already spoken about. Dyslipidemia is another issue. Estrogen helps in increasing HDL. We don't have good medicines for that. Estrogen increases HDL and also reduces LDL and triglyceride cholesterol in a dose-dependent manner. So these drugs will help in managing all metabolic dysfunction. Because it is lipid-friendly, antiplatelet, and endothelial protective, that is why MHT is suggested for cardio protection. Even for cerebro protection, the Women's Health Initiative showed that there was no increase or there was no decrease in risk with MHT. The drugs are safe to use. Again, what these studies show us is that there is a timing hypothesis or a window hypothesis. The earlier we initiate MHT, the better the result. So, maximum 10 years, and some people say 4 years, you should initiate within 4 years. The younger the woman, the better the reduction. So, once again, hit early, hit hard. And if you do so, you will be able to improve survival, improve CV outcomes. You will have a reduction in all-cause mortality, reduction in coronary artery disease, and for venous thromboembolism, there may be a slight increase. We have to be careful. For stroke, we will be neutral. So the earlier we start, the better, and we should not miss this window of opportunity. How do we know the window that is there? Take a history of menopause, take a history of vasomotor symptoms, take a history of local genitourinary tract abnormalities, and also look for osteopenia. If you initiate in time, you will be able to improve quality of life, cardiovascular health, and bone health as well. Like we said, MHT, estrogen, is able to prevent osteoporosis. That is important. Now, this is a very person-centered decision. We need to prevent osteoporosis. We need to prevent fragility fractures. When should we start? Should we start when the BMI goes, when the body mass, the bone mineral density goes below 2.5, or should we start early? With estrogen, we have osteoblastic activity, and we are able to prevent all the complications of osteoporosis. Of course, this is not to say that you should give estrogen alone when you want to prevent osteoporosis. Remember the role of vitamin D, calcium, and exercise, weight-bearing exercise. Many of us will say, not have access to bone mineral density. DEXA is too expensive. But then we use a fraction. So you can get free of cost, just download it. That will tell you the risk of fracture in a particular bone. Gentlemen, and you can use that to inform your health. But certainly, when we give MHT, that is estrogen and progesterone, we are able to improve bone mass. So that is fine at the femur. And just repeat once again, it is a tip for the prevention of postmenopausal osteoporosis. So if somebody is high risk, this is breathing exercise. Ensure stress management, spirituality, spiritual and ensure sleep hygiene, and don't forget God's blessing to us, that is sunshine. So let's repeat again. If a woman comes to you with vasomotor symptoms or local genitourinary symptoms, if she is at high risk of osteoporosis, we should use the drug. At the same time, if the woman is going through distress, what does menopause distress mean? Menopause distress is defined as an emotional response. So she is going through a hyper-emotional phase characterized by significant and persistent apprehension, discomfort, or dejection. She is afraid. She is uncomfortable. She is sad because of a perceived inability. She thinks that she is unable to cope with the biomedical and psychosocial demands and challenges of living with menopause. This is menopause distress. So let us repeat again. A woman who comes to you, a lady who comes to you with significant and persistent apprehension, discomfort, or rejection, because she feels that she cannot cope with the challenges and demands of menopause. Such a lady has menopause distress, and MST would help her. MST also helps in cognition, actually. So there are studies which show that estrogen improves verbal memory if started early, improves global cognition if started early in surgical menopause. So it keeps your brain younger as well. Of course, there are many challenges to MHT. We ourselves sometimes are not able to give enough time to the subject. So I would like to commend EMSON and thank them for including this important topic in our conference. The public also has different opinions, so we should make the public aware about the importance and the safety of MHT, provided it is monitored by an endocrinologist or gynecologist. Also, we should lobby and advocate with our policymakers to make MHT more economical and more clear. See if the patient has an intact uterus or not. If she does not have uterus, or she has progesterone intrauterine device in situ, then we will give estrogen. We can choose tablets, gels, or patches. Gels and patches are a bit more expensive. Preferred in people with high triglycerides and in those with history of venous thromboemboli. Otherwise, oral is fine. If the patient does not have uterus, such as then estrogen would be better. You can use sequential therapy or continuous combined therapy. Sequential means we give for 28 days, then let the patient have her periods. Continuous combined means you dose continuously so that there are no periods. You can give oral or transdermal. Mostly I use oral methods. But when we are treating menopause, do remember the concept of quaternary prevention. Quaternary prevention means ensure that you do not overtreat the patient, do not cause side effects. So that means we have to do a full assessment, a medical, endocrine, and gynae assessment. Above 45 years, symptoms will suffice, but below 45 years, do check an FSH and estradiol. FSH should be above 25. Newer drugs are available, which I do not have personal experience with. They are not available in India. Bazedoxifene, Tibolone we have used in the past. It was available earlier in our country, but is not available now. And etostrol is E4. Like earlier, when I was a student, we had 3 types of estrogen. Now we have 4 types of estrogen. The fourth one is E4. It is a native estrogen with selective tissue activity. It has naturally the fetal liver, and it can be used as a pharmacological therapy for menopause. And the results are considered much better with E4 as compared to placebo. These are newer drugs. When your patient is on MHT, she may ask, can I discontinue? Or after discontinue. So you might want to discontinue suddenly or after giving alternate day therapy. Both are fine. Both will have the same result. In case your patients continue beyond 10 years, still they will have lesser mortality, lesser CA breast, CA lung, and CA colon, lesser heart disease, and less dementia. Though they might have increase in breast cancer. Let us summarize with guidelines. Guidelines from across the world, from USA, from Europe, global guidelines say that you must use this drug for treatment of symptoms. Most of the old guidelines do not recommend it for prevention of disease, but FDA allows it for prevention of osteoporosis. Use up till 10 years after menopause or up till the age of 60. 10 years after menopause or up till the age of 60, and keep on monitoring for cardiovascular health and mitogenic health. Use for short period of time if the patient has vasomotor symptoms. Use for short period of time if the patient has genitourinary symptoms. But if the patient wants to continue, you are welcome to do that. If we want to prevent osteoporosis, some people have suggested a T-score threshold of less than 1.8. Use whatever drug is available. I personally use estradiol valerate and dydrogesterone. And once again, remember to be holistic. Talk to the patient, talk about her symptoms, her complaints, but also talk to her about her concerns and challenges. Talk to the family as well. The husband, the daughter-in-law, the son. Make sure that everybody supports their wife, their mother. Help not only from a biomedical perspective, but also in stress management. Be person-centered, be woman-centered, and once we are able to do that, we will have achieved the main enjoyment, the main pleasure, the real pleasure of being an endocrinologist. Thank you, and I look forward to further discussion.
Thank you very much. Thank you very much, Professor Kara, for that very lucid lecture. Do you want to do a quick recap? Okay, so we'll have a 2 minutes recap, and then we'll take questions and comments for Dr. Kara.
Thank you, Dr. Oloku, and warm greetings to everyone. It is a great pleasure to be with you virtually, and I hope to be with you physically in the near future. God willing.
Thank you very much.
Menopause is more and more important because we are living longer and longer. Also, we are expecting more from life. We expect more from life than we expected before. Many times, the general public, criticize us for medicalizing a normal physiological event. But actually, it is the opposite which is correct. Imagine a 50-year-old lady who has pain in the joints, who has genitourinary symptoms, who has hot flash. I hope I am audible.
Yes, we are with you. We are with you. We will take questions, and you respond to the questions. Then we will do the closing part of the discussion. Is that okay with you, Sandy?
Yeah, okay. So,
Thank you.
imagine a lady who has symptoms. What will she do first of all? She will go to her sister-in-law, a friend. She will tell her friend, I have got these complaints. What will the friend say? I also have the same complaints. No need to go to the doctor. Actually, we are normalizing. As endocrinologists, we should be able to explain to the community that menopause can be managed, menopause must be managed, and we have multiple ways of managing. Whether it is psychosocial support, calcium, vitamin D, or menopause hormone therapy, we should be able to offer all of these to the person who needs them.
Very much.
And greetings to Dr. Ali Mahmoud and Dr. Olopade. Thank you so much for your comments in the chat box.
Thank you so much. Thank you. I don't think there will be time enough for a rapporteur's report, but Dr. Sanjay Kara is a member of EMSON. That followed his approval as a member of EMSON when he delivered the keynote lecture in 2021. You recall in our 2021 EMSON AGM Scientific Conference, the keynote lecture was on thyroid disorders in Nigeria, challenges in management. That was our first and ever only virtual EMSON AGM scientific conference. After an excellent delivery just like this, it was approved by the elders and the leadership that membership of EMSON be extended to Dr. Sanjay Kara. So he has been part of us since then, and we have been in touch. Thank you so very much. We'll just take a few questions and comments, and you will respond to those questions and comments, and then we will do a brief closing. So are there questions and comments, please? I know just yesterday I talked about osteoporosis in postmenopausal women, and I'm happy that some part of his lecture touched on the aspects I discussed. So we welcome questions, comments. Yes, Professor Odeni.
All right. Thank you, Sanjay. I want to ask your experience. Have you had a woman who is a menopausal with carpal tunnel syndrome that is difficult to treat?
Any more questions so that we can take it together? Questions, comments? Okay, Sanjay, you could go ahead to respond to the question. Menopause and carpal tunnel.
So no specific experience regarding the impact of MHT on carpal tunnel syndrome, but I guess I would get a thyroid test done first. And if there are other indications like local genitourinary complaints or vasomotor symptoms, then I would start MHT.
Thank you very much. Thank you. Any more questions, comments? Okay. So what is left for us now is to do a brief ceremony while really appreciating Professor Sanjay Kara for an excellent delivery. To do that, I would like to invite Professor Fasamade. He stepped up. Okay. I would like to invite Professor Kolawole to come and receive this plaque on behalf of Professor Sanjay Kara. Don't worry, Sanjay, we will get this across to you very soon.
Thank you.
So it's Professor Anuma, do you mind coming to hand this to Professor Kolawole on behalf of Sanjay Kara? Thank you, man. Thank you, man.
So, on behalf of the Endocrine and Metabolism Society of Nigeria, we want to give this plaque as a form of appreciation for the beautiful lecture that you have given us on menopause. Professor Kolawole is standing for you to receive this.
Thank you, madam. Thank you, ma'am.
So, Professor Sanjay Kara, we want to thank you very sincerely for joining this meeting. And we hope that you will find time to continue to be with us until the end of the meeting tomorrow. Thank you so much. Our love to your family. Bye-bye.
Thank you. Thank you. Greetings, everyone.
That brings us to the end of this first plenary.